Welcome to the CAA 2023 webinar series. Today's webinar is Palliative Paramedicine, Challenging Perceptions, Building Paramedic Capacity and Embracing Integrated Models of Care, presented by Ms. Madeleine Juhrmann. Thanks for joining us and please enjoy.
Hello, my name is David Waters and I'm the Chief Executive of the Council of Ambulance Authorities. Welcome to the latest in our webinar series. Today's webinar is titled Palliative Paramedicine, Challenging Perceptions, Building Paramedic Capacity and Embracing Integrated Models of Care. Today's speaker is Madeleine Juhrmann. She is a final year PhD candidate at the University of Sydney's Northern Clinical School and research assistant at the HammondCare Palliative Centre. With a clinical policy and research background in paramedicine, public health and palliative care, Madeleine's key interests lie in improving care for people with life-limiting illnesses and reducing avoidable hospital admissions. Her PhD focuses on broadening the role of paramedics delivering palliative and end-of-life care in Australian communities. As part of this research, Madeleine is developing a palliative paramedicine framework suitable for national implementation to standardise best practice and embrace integrated models of palliative care. Please join me in welcoming Madeleine. Thank you.
Hi everyone, my name is Madeleine Juhrmann and I'm from the University of Sydney. Today I'm going to be presenting on my PhD, which is related to palliative paramedicine. So my presentation today is titled Challenging Perceptions, Building Paramedic Capacity and Embracing Integrated Models of Care, Findings from a PhD exploring the role of paramedics delivering palliative and end-of-life care in Australian communities. I have no conflicts of interest to report. So as a non-clinical researcher conducting health services research in paramedicine and palliative care, it's really important to explicitly acknowledge my background, worldview and standpoint as a researcher, because these factors certainly shaped the approach that I took for my PhD. So I decided to embark on this PhD after significant personal reflection arising from lengthy discussions with Australian and international paramedicine and palliative care experts regarding my earlier experience working as a student paramedic. During these formative years, I witnessed firsthand the limitations I and paramedic peers, many well advanced in their career, felt when caring for the patients with life-limiting illnesses in the community. Despite coming across aging and dying patients each shift, I had not received any curriculum related to palliative care throughout my undergrad degree, and I felt completely ill-equipped responding to end-of-life frailty and expected death call-outs in the community. In fact, I quite feared the unknown in caring for these types of patients, and instead I felt much more confident responding to typical pre-hospital emergencies such as cardiac arrests and motor vehicle accidents. I initially considered this limited scope of practice a phenomenon that any Australian junior paramedic should come to expect. However, upon later completing an international placement with Costa Rica's Red Cross, I experienced the same unmet need for palliative paramedicine in a middle-income country. And that made me realise that these inadequate palliative care capabilities transcended our ambulance service design and demography to other contexts as well. So acknowledging this restricted scope of practice, coupled with the collective experiences and perspectives of other generalist palliative care providers I'd come to listen to and admire, I became motivated to address this gap in Australia. Consequently, I ceased my clinical aspirations as a paramedic and I undertook postgraduate studies in public health before embarking on a career in palliative care policy and research. And so any researcher focusing on health professions they no longer practice in must balance idealism and pragmatism when advocating for service reform. So throughout this PhD, I've held a positionality of a researcher with lived experience as a paramedic, but I've remained really aware of my limited understanding of contemporary paramedic practice in Australia since leaving the clinical space. So as a result, I have welcomed diverse and contrasting perspectives from clinicians on the front line regarding the role paramedics ought to play delivering palliative care in community-based settings, and recognising my personal beliefs should never skew their anecdotes or suggestions. I've also aimed to maintain impartiality when interpreting and reporting the results, especially those that do not align with my personal beliefs, because recognising that and challenging one's preconceptions only strengthens the research process. So in summary, driven by my early experiences from the outset of this PhD, I wanted to generate practical improvements in the field of palliative paramedicine. As a result, I established key goals to inform the direction of my research, including engaging the subjective insights and endorsements of paramedics and other key health professionals currently working in palliative paramedicine to shape the outcomes of my research, and also translating the findings into practical outcomes in real time. And my background in public health has also influenced this research approach, as I hold strong beliefs that the broader social and structural determinants also influence health outcomes pertaining to palliative paramedicine in Australian communities. And this in turn has driven my research focus beyond mediating clinician-focused level of challenges towards a multi-sectorial solution. So this is a quote that I'd like to begin this presentation with, which is captured during a qualitative interview study by an intensive care paramedic, which really summarises, I guess, the theme of today's presentation. Palliative care breaks a narrative for paramedics that we are lifesavers. So this PhD aims to investigate the current role of Australian paramedics delivering palliative care, exploring how their scope of practice could be broadened to improve patient outcomes in end-of-life care. In doing so, I aim to develop a palliative paramedicine framework suitable for national implementation to standardise best practice across Australia. My PhD consists of 4 studies, as listed on this slide, which I've completed over the course of the past 3.5 years. I'll provide more details on each in subsequent slides. And underpinning the studies, I also developed a palliative paramedicine advisory group, which I'll talk about in the next slide. The ultimate goals of this PhD include enhancing out-of-hours emergency care, reducing avoidable hospital admissions, facilitating more home-based deaths, improving end-of-life care for people with life-limiting illnesses, and building an oceanic community of palliative paramedicine practice. So to build capacity within the palliative paramedicine sector, I established a palliative paramedicine advisory group at the beginning of my PhD. I leveraged existing paramedicine contacts and approached all ambulance services in Australia and New Zealand, seeking their interest to take part in the oceanic community of practice. Gaining substantial buy-in, all jurisdictions willingly participated and elected a suitable senior clinical manager to represent their service throughout the duration of my PhD. I also invited select palliative care thought leaders with paramedicine expertise from both countries to become members. And the purpose of this group was to strengthen and promote collaboration between all of the ambulance services on matters related to palliative care. And also ask each of these services to advise on their current operational barriers and developments specific to the provision of palliative and end-of-life care. I invited the advisory group members to co-author and participate in the PhD studies. And this facilitated research experience for particularly those advisory group members who are clinicians only and previously had not partaken in research. And it also helped drive the translation of our findings into practice in real time. So our group met annually via video conference throughout the course of my PhD, and their contributions are always acknowledged in all lay and academic presentations and publications arising from this research. So moving to the studies now. Our first study, which is listed here, you can access it using the QR code there. It was published in Palliative Medicine Journal in 2021, and it aimed to review and synthesize the international and empirical evidence regarding paramedics delivering palliative and end-of-life care in community-based settings. The review supported an expansion of current paramedic practice beyond traditional models of treatment and transport to hospital. The study described a need for improved communication and support channels between paramedics and multidisciplinary palliative care teams to improve paramedic end-of-life care capacity. Importantly, the study identified clinical practice guidelines as key enablers for standardising practice, and this finding really shaped the direction of our next study. which was to examine the quality and content of existing Australian palliative paramedicine guidelines with a sample from comparable Anglo-American ambulance services. So the study engaged an international multidisciplinary team, including 5 members of the advisory group. The study took part over 2 stages. First, we assessed and critically appraised the quality of the guidelines using the Agree To instrument, which fortunately 2 members of our authorship team already had experience using. Next, we reviewed and critically analysed the content of the guidelines using a qualitative content analysis approach. We included the 5 existing Australian palliative paramedicine guidelines, as well as the New Zealand and UK national guideline, plus 1 from a Canadian jurisdiction of best practice. It's irrelevant to note that 3 of Australia's ambulance services still do not have a specific guideline pertaining to palliative care here today in 2023. So the findings of the study suggest ambulance guidelines are shifting away from protocol-driven paramedic practice to broader clinical models, calling on the discretion and the decision-making skills of paramedics instead of those traditional fixed algorithms. The study also highlighted the opportunity to shape future practice on integrated models of care, and we identified future research could translate the palliative care skills of specialist paramedics across to the generalist paramedic workforce. So for those in Australia thinking about the skills and capacity of, say, an extended care paramedic and ensuring that some of those basic palliative care approaches can then be conducted by a generalist paramedic as well. However, perhaps most importantly, this study highlighted the need to take a multifaceted approach to broadening paramedics' role in providing palliative and end-of-life care in communities. We quickly established that guidelines alone will not improve practice. I'm delighted to report the findings of this study have already been translated into practice with the new Northern Territory Ambulance Service Palliative and End-of-Life Guideline. And these findings certainly influence the trajectory of our next study. So again, you can access the publication here using the QR code. It was published in 2022, again in Palliative Medicine Journal. So our third study was a qualitative study to elicit key stakeholders' perspectives, experiences and attitudes of palliative paramedicine in Australian communities. 50 participants took part in the study, representing all jurisdictions of Australia. They included paramedics, palliative care doctors and nurses, GPs, residential aged care nurses and bereaved family carers with lived experience of palliative paramedicine. I've included a quote here from one of the residential aged care nurse participants, stating, "Paramedics are a highly regarded profession and have the power to communicate convincingly with families. They help us to take a palliative approach, especially after hours." The results of the study were separated into 2 papers. The first publication focused on the role, barriers and enablers of palliative paramedicine practice as articulated by the participants. And this slide illustrates the thematic analysis diagram of our analysis. We concluded an individual's rationale for objecting or endorsing palliative paramedicine ultimately determines their perception of the barriers, enablers and opportunities for improving practice. And so 2 broad dichotomies of thought were expressed amongst the participants. Firstly, some considered the paramedic role ought to be rooted in responding to acute emergencies and adhering to that traditional perception of paramedics treating a patient to save their life. Contrastingly, other participants considered the paramedic role is evolving in response to the diverse and changing needs of the population, which also includes an increasing demand for community-based palliative care. Both of these paradigms of thought were influenced by 4 key themes and sub-themes as listed on this slide. Firstly, creating an identity there on the left. Paramedics have a revered public identity shaped by a perceived ability to fix a crisis. Next, fear and threat. Paramedics are often afraid of palliative and end-of-life care and feel vulnerable when taking this approach to care. Next, permission to care. Paramedics require consent to move beyond the traditional model of care. And finally, the harsh reality. Paramedics ultimately will always offer an adjunct support for community-based palliative care. So this study, again, was published in Palliative Medicine in 2023. And the study's findings suggest balancing competing priorities of what might be the appropriate goals of care for a person who appears to be dying and the family's expectations requires a high degree of clinical skill and discretion amongst paramedics, which could perhaps be facilitated in the future by universal access to electronic medical records. We suggest ambulance services ought to review current palliative care guidelines, training and interdisciplinary practice to optimise their role in the context. And future research could investigate strategies for overcoming prohibitive paramedicine cultural norms related to palliative and end-of-life care, ultimately enabling a smoother transition for paramedics to provide high-quality care for people with life-limiting illnesses. The second paper, which is currently under peer review, explored opportunities for improving palliative paramedicine in Australian communities. Employing thematic analysis principles, we classified the participants' suggestions for improvement into three broad categories. First, systems-based macro-level interventions, there on the left. Second, service and community-based meso-level interventions on the right. And then third, individual clinician and consumer-based micro-level interventions in the middle. This slide illustrates the three levels of interventions and the subcategories of improvements suggested by the participants. From a macro level, participants called for a greater inclusion of paramedicine in palliative care policies and frameworks, more targeted funding and education initiatives, and the ability for paramedics to access electronic records while on scene with a patient. And finally, a widened scope of palliative care practice. From a meso level, participants suggested standardised palliative care training across all ambulance services, greater interprofessional understanding and communities of practice between paramedics and other palliative care providers, and the ability to treat and refer, and improved levels of community understanding regarding how paramedics can play a role in palliative care. Finally, from a micro level, participants called for equipping paramedics with generalist palliative care capability and offering specialist pathways to those demonstrating aptitude and interest. Other micro-level suggestions also included greater debriefing and self-care pathways for paramedics involved with palliative care patients and a focus on partnering and care with families. So this study is currently under peer review with the Medical Journal of Australia. And these findings helped shape the components of our final study. So this year we conducted a Delphi study to develop a palliative paramedicine framework which would be suitable for national implementation. We gained consensus regarding the framework components considered most essential for improving the role of paramedics providing palliative and end-of-life care in Australian communities. We recruited paramedics, palliative care doctors and nurses and general practitioners, as well as researchers and carers with lived experience and expertise in palliative paramedicine to form the expert panel, some of whom were members of our advisory group or had already participated in our previous qualitative study. Australians were the largest participant pool of the sample, but international experts were added to provide a wider perspective and increase the likelihood of this framework being relevant in other comparable healthcare systems. So 68 participants took part as part of the expert panel in round 1 and 66 in round 2. We conducted the Delphi using an online questionnaire, and we shaped the components from each of our previous 3 studies. Each Delphi round informed the need for and content of the next round. So round 1 included 24 original components separated into those 3 sections: macro level, meso level, and micro level. Experts were asked to rate their level of agreement for each component to be included in the final framework using a 5-point Likert scale. Free text comments were also sought during this round, allowing the expert panel to modify the existing components and make suggestions for new components not already covered. 17 of the original 24 components gained consensus, and 6 components were modified, and 9 new components arose from round 1. All modified and new components gained consensus in round 2, and only 1 original component did not gain consensus across both rounds and was ultimately excluded from the final framework. So the final framework consisted of 32 components, as demonstrated on this slide. So standardising best practice to optimise the role paramedics can play requires a multifactorial approach and geographical nuance, especially in a country as large and as diverse as Australia. So this study allowed a group of international multidisciplinary experts the chance to deliberate the best available evidence, employing their experiential expertise to achieve consensus on a comprehensive range of 10 macro, 11 meso, and 11 micro level components for inclusion in the final framework, which would then be suitable for national implementation. The components included structural, healthcare service, community, clinician, and consumer level interventions. As this manuscript is currently under peer review, I cannot share the full details of the framework. However, perhaps most prominent amongst the experts' first round of feedback was the demand for stronger inclusion of bidirectional training and multidisciplinary debriefing opportunities between ambulance services and other palliative care providers. These findings are supported by Canadian and American models of palliative paramedicine practice, which substantiate the power of formalising communication and education channels between paramedics and palliative care clinicians. By requiring each jurisdiction to establish training and debriefing networks between ambulance services and local palliative care providers, including GPs and residential aged care providers, mutual understandings of the capacity, strengths, and weaknesses of each sector could be fostered, which would in turn lead to greater awareness of interdisciplinary palliative care capabilities and a reduction in siloed care. To continue challenging the curative treatment and transport orthodoxy of ambulance services worldwide, paramedics need to be supported to make complex clinical decisions with confidence and navigate holistic care pathways that prioritise referral functions available to other community-based clinicians. An omission from our original components that was identified by the expert panel's feedback in round one was the need for clinician backup support pathways for paramedics at the point of care. Our authorship team assumed this would already occur in a generalist sense without articulating in it in the Australian context, as some jurisdictions already have these processes in place. However, the round one feedback indicated the expert panel considered specialist palliative care support a desirable framework component, even if it was only available via telehealth. In conjunction with formalising training and debriefing opportunities between ambulance services and other palliative care providers, ensuring Australian paramedics have round-the-clock phone number to call for specialist palliative care clinical support will be an integral step towards incorporating paramedicine into the multidisciplinary palliative care landscape. The only component to not gain consensus across both rounds pertain to modifying ambulance services call algorithms to prompt further questioning about a patient's palliative care status and to notify paramedics when they arrived on scene. While this was suggested by participants in our previous research to help with triaging, some of the expert panel commented this could be a risky strategy and challenging to implement, certainly food for thought down the track. So future research ought to engage a multidisciplinary team to modify an implementation strategy, addressing any perceived barriers, facilitators, and challenges for applying the framework into policy and practice. The arising implementation strategy should seek the endorsement of professional associations, apply a theory to guide the next steps, and acknowledge the time and resources required to standardise palliative paramedicine practice across Australia, the findings of which could have resonance for palliative care providers and ambulance services worldwide. So I'm now at the end of my PhD journey, due to submit my thesis in December of this year. However, this is certainly not the end of my efforts to see this framework come into fruition. Next year, I plan to conduct focus groups with select members of the Delphi expert panel, alongside palliative care and paramedicine peak bodies, policy experts, and implementation scientists to develop a comprehensive implementation strategy. I will then seek funding to implement and evaluate the framework within Australia with an aim to standardise best practice and strengthen a culture of interdisciplinary palliative paramedicine across the Oceanic region. And I think this quote from a family participant sums up the findings of my research well. If someone is having a terminal event, you need some drugs to give them quickly to relieve that distress. I remember thinking, thank goodness someone's here to back me up. It was a combined effort to manage Dad's distress, and there was no pressure from those paramedics to take him away. So this particular participant was a family carer of her father, and she also was a palliative care nurse. Despite this expertise, she found paramedics being able to call them in the middle of the night extremely helpful in keeping her father at home and facilitating his goal to die in his home. So thank you for listening to my presentation today. I'd like to acknowledge my wonderful supervisors, Professor Josephine Clayton and Professor Phyllis Buteau, as well as Associate Professor Mark Bowie and Associate Professor Paul Simpson, and the wonderful HammondCare team for their tremendous support and contributions along the way. Also, a big thank you to the Palliative Paramedicine Advisory Group and all of the study participants. Without you, this research could not exist. So I'll now hand over back to have a Q&A. Thank you very much.
Thank you, Madeleine. Firstly, a big thank you for shining a very important light on this topic. Certainly, if it wasn't for researchers like yourself, some of these really important areas of care would remain, I guess, undeveloped in as far as there's so much more we can do. You've been on this journey for a little while now, Madeleine, on your PhD journey, obviously. Have you seen any changes in paramedic education in the palliative care space during your time?
I think that can be best demonstrated by the fact that when we started this research, only 22 studies were included in our systematic review, and some of them were pertaining to education and training. There's now an abundance of literature that has been published over the past 3.5 years, and we're seeing an increasing appetite amongst ambulance services, not only within Australia, but internationally, and across both the Anglo-American and the Franco-German divide, recognising that, you know, community demographics and the fact that we are living longer and wanting to die at home and in place is requiring greater expertise from generalist services, not just specialist palliative care services. And so ambulance services across Australia, I can speak to specifically, are doing an amazing job at incorporating training both within undergraduate curriculum, but also into graduate capabilities for their grad paramedics, all the way through to senior positions available. We've seen most recently in Victoria, they've announced that they're going to be beginning paramedic practitioner roles, which will give paramedics, I guess, a trajectory or a pathway to further specialise beyond an ECP capacity. And within that, they're already highlighting the suggestion of a palliative care specialisation. So I think the appetite and increasing awareness of the role paramedics can play is being reflected in both policy and practice and education opportunities.
That's really great to hear. The undergraduate paramedic courses across Australia and New Zealand, we now have, 21 of them. They're always stuffed full of stuff. It's really hard to get airtime on specific topics like palliative care. Have the universities responded to this increased requirement to have broader knowledge around palliative care?
Yeah, great question. They have, and I think that there is a significant change in prioritisation of both community mental health within curriculum now and compared to when I did my undergraduate degree. And that again is just reflected by what ambulance services are seeing and responding to. And I think another massive reason for this change of practice, or kind of like this challenging the traditional perspective, has been the issue of ramping. We're seeing paramedics in ambulances unnecessarily waiting to get into an ED. And we know that if we're able to provide the types of care in the community and reduce avoidable hospital admissions, not only are we facilitating greater care for the patient, but we're also ensuring that the paramedics are not getting fed up with their role and the frustrations that they experience. So universities are doing a great job. I've been in contact, courtesy of Associate Professor Paul Simpson, with all of the deans of the universities across the Australasian region, so New Zealand as well. And I think that, as you said eloquently, you know, it's always going to be a fight for finding the room in the curriculum, which is already jam-packed. But I think something that is really important to recognise is that palliative approaches to care, they transcend so many different pathologies and diseases. And if you are equipping paramedics with that holistic approach, it's really going to allow them to actually benefit in their care for so many different presentations, not just simply someone at end of life. And that palliative care isn't just for people in their last hours or last days or weeks. It's, you know, recognising the nana in the care home who may have something that is a reversible cause, but can we reverse that cause here? Even if she's not imminently dying, can we take a palliative approach here in the care home and treat and refer and reduce an avoidable hospital admission through that palliative approach to care?
Absolutely. I've got a couple of questions from our audience. Firstly, from Samantha. Firstly, great presentation. Thanks, Madeleine. Out of interest, do you think there is a place out there for paramedic palliative care practitioners available 24/7?
Great question, Samantha. Thank you for asking this. This has been a huge point of contention in not only my PhD, but in the broader academic literature out there. There's a suggestion that we should relegate palliative care to specialist paramedics only, as has been the case historically in South Australia when they pioneered the ECP program and they had palliative care capability. What we've found as time has come on is that if you are relegating to a specialist role, as the increasing need and demand for palliative care becomes apparent within the community, you will see a deficit in the ability for all paramedics to be able to provide that care. So if the specialists aren't readily available or they're doing other community care work and you send a generalist team, generalist crew to the patient, if they don't have the skills and scope to be able to take a palliative approach, they will take the patient to hospital. And they're the avoidable hospital admission and the ramping process that we were talking about. I do recognise that paramedics don't go into paramedicine normally to treat people in the community, and that we do have an appetite for responding to those motor vehicle accidents and those cardiac arrests. So it is important to recognise that not all paramedics will have an appetite for palliative and end-of-life care. What I argue for and what the literature and evidence supports, both within Australia and in comparable health systems overseas, is that all paramedics should have a generalist baseline capability, and those paramedics that are expressing competence, interest and aptitude should have the opportunity for a specialist pathway, just as you've described.
Excellent, thank you. I have a question from Tony Walker. Hi, Tony. Fantastic presentation, Madeleine. What do you feel are the biggest barriers to fully implementing palliative care into ambulance practice?
I anticipate that for a really long time, paramedics have been seen as an other. They haven't necessarily been seen as a fully incorporated or integrated health profession. And with the advent of the 2018 registration of paramedics in Australia under APRA, we're seeing momentous change in the way in which paramedics are regarded in the healthcare system. The same can be said within New Zealand and our other oceanic countries of comparison. However, I think we do have a lot of I guess, improvement to be made in terms of recognising the role that paramedics can play in conjunction in that integrated model of care. We want to preserve our ability to respond autonomously and keep that brilliance that we have of being in all jurisdictions, all locations, 24 hours, 7 days a week. But we want to be respected in the way in which we are able to engage in patient care. And I think that there has been a lot of turf protection in the past, especially from specialist palliative care providers, in not wanting to share their patients through fear that if they do, they will lose, I guess, their justification for their specialisation. I really don't think that's ever going to be the case. It's going to be convincing, I guess, that integrated approach across the spectrum that it's going to be really difficult. Another really tricky thing, I think, is going to be convincing at government, both at a federal and then at a state and territory level, the need for paramedics to have access to electronic medical records, because we know that that is a key enabler in allowing a paramedic, particularly a generalist paramedic, the confidence and scope of practice to be able to go, I'm not going to conduct CPR here. I'm not going to give them this. I am going to keep them at home, and giving them that legal latitude to not be fearful of what the repercussions will be. We've seen in Queensland already the extension of paramedics to be able to access these types of documentation, and the outcomes are impressive. So those are my two kind of big big picture barriers that I perceive as being most difficult. But I'm sure there'll be plenty more along the way, hence why we want to conduct a really rigorous process in developing an implementation strategy for this framework.
Absolutely. That's awesome. Mel's asked a question that is probably along the lines of the question I asked you a little bit earlier, but slightly different. Have you done any work with universities to look at curriculum alignment in regards to coverage of palliative end-of-life care?
Thanks for your question, Mel. Great question. Yes, we have. So we have been working with the University of Technology in Queensland to develop I guess, curriculum that pertains to palliative care and paramedicine, and recognising the, I guess, the learning outcomes and the attributes, the graduate attributes that we would hope to be developed from this. We have created a paramedic palliative care workbook and whole range of resources, learning resources that are modules, e-modules, that can be incorporated into existing platforms. These are predominantly for graduate capabilities and for existing ambulance services, but we're looking at translating these also then into university curriculum. I recognise that universities are not a one-size-fits-all, and that the needs are going to be really different for students in different areas and jurisdictions. But I warmly welcome collaboration with universities, and have already had many of them reach out to me and to the PCC for U team at QUT to kind of not reinvent the wheel. If we've already got something working, let's try and modify it and adapt it so it can be suitable for each university's curriculum, because we understand that they're unique. And, you know, some are doing trimesters, some are doing semesters, some are 3 years, some are 4 years, but we're really ready to adapt and modify according to the needs of the unis.
Great, that's wonderful news. Jenna from New Zealand had a question. Jenna is a extended care paramedic in NZ and has a postgrad qualification in palliative care. And she's currently working as an advanced care planning facilitator in the South Island of New Zealand. Her question is, do you have any input around paramedics being hired by specialist palliative care teams or in-hospital palliative care teams outside of traditional ambulance services?
Thanks for the question, Jenna. You've really shined a light and premeditated one of our recommendations to come out of the framework, which is to challenge the conception that paramedics should only be working in ambulance services. We know that paramedics have unique skills and capabilities, and it was the COVID pandemic that highlighted the ability for paramedics to be able to actually work in other settings, particularly GPs, and I cannot see why there would not be a reason for specialist palliative care teams as well. And that is already happening overseas in the UK, in Canada, and there's already some talk about it occurring also in Australia as well. Next year in February, I'll be conducting a education session with the Australasian College of Paramedicine, and we'll be inviting one of the specialist paramedics who works in Cambridge in the UK for a specialist palliative care service, and they've been pioneering this exact role that you're talking about, which we hope to kind of develop and adapt that so that it can be suitable for both an Australian and New Zealand context. So really good question, and you've certainly beat me to it. That's definitely what's in the pipeline and what we hope to achieve. As the earlier question suggested, I'm really passionate about building generalist capability, but also enhancing those opportunities and those pathways for paramedics with that skill, that aptitude, that interest, to be able to have a way to be able to, you know, work in this capacity and in this field, maybe just not restricted to an ambulance service.
That's amazing. Great. Thank you. We look forward to an update in that space. I've got a question of mine, Madeleine. It's in regards to your comparative guideline analysis. One of the challenges we find in ambulance services in Australia and New Zealand is that our guidelines aren't necessarily always written in a manner that fits with agree to as an instrument. I just wondered if you came across that in this space, and I'm really interested in the level of variance you saw when you did your comparative analysis.
Great question, David, and definitely something that we came across. We had two participants, or two members of our co-authorship team, who were actually advisory group members as well, who had previous experience using the AGREE tool. We came across this similar limitation in that the AGREE instrument, it's actually not about, I guess, assessing the content of the guideline or arguing for, I guess, its clinical validity, but rather assessing the methodological rigor with which it was developed. One key finding that we've found, and that previous studies have also highlighted, is that ambulance service guidelines often are not developed rigorously. They're quite ad hoc and in an algorithmic approach, and that there is opportunity to improve the way in which they're developed in a more academic approach. However, the AGREE instrument is blunt in being able to define whether a guideline, because it doesn't methodologically look great, whether it actually works in practice, because we know that they do work in practice. But one of the key findings that we've also seen, and that we observed and have seen since the study was published, is that ambulance services broadly are moving away from that kind of protocol approach of algorithms of very black and white, this is what you do, this is how much you give, this is how you can do it, to a more guideline approach, which is suggestive and broader in its outline and capacity. I would love to see the AGREE instrument broadened to be able to recognise different ways in which guidelines can be developed, and also acknowledge that we're not talking about clinical validity here, we're talking about methodological rigour. And we certainly outlined that in our study. It was one of the key findings that we put forward. Great question though, thank you.
Well, thank you. I'm also interested in your excluded criteria that I think related to the AMPDS algorithm for palliative care. Can you expand on that? Why it was not included?
So we're referring to the Delphi study, which was the final study. One of the only components that didn't get thought through in that study was with regards to incorporating, I guess, part of the call taker's algorithm to include a question relating to palliative care. So, for instance, is this patient in under a palliative care program, you could say. Now, we developed all of the components for this for the Delphi study from the findings of the previous studies, and in the qualitative interviews, numerous participants suggested that a change to the algorithm could actually really help early identification of a palliative approach, and also even in some circumstances prevent lights and sirens and paramedics coming in with a curative focus. We wanted to test that with the expert panel, and what came back really was there was no consensus on the inclusion of that. The main justification, as recorded by the qualitative responses we received from the participants, was that it raises too many questions, and the concern that it couldn't necessarily be methodological and systematic across the board, and that it would potentially leave a risk of highlighting a patient as being palliative when they are indeed not, or that they have a reversible cause that does indeed need hospitalisation, but by relegating them to this palliative condition or, I guess, triage, that it could lead to further problems around down the track. Now, I appreciate that it was excluded from the framework this time round. I do think that it needs further I guess, investigation, and when we do the focus groups, I'll certainly be bringing that up with some more nuanced conversation around how could we incorporate a similar idea, or does this even have merit? Should we be pushing for this or not? Because we've seen it being included in international studies, particularly in Scandinavia, where they've had it to good effect. But the way in which they work, the ambulance services work there, the call takers do have some clinical background and expertise, which has made us think maybe we could include instead, rather than an algorithmic question, more of a flagging for the call takers to then gain medical expertise from, say, an ECP that's already in the call taking centre, or the medical director, to be able to discern whether this call does indeed need lights and sirens, or how we should dispatch the ambulance accordingly.
Excellent, great stuff. There's a couple of other comments in the chat that I'll just share with you out of interest, Madeleine. Leanne, who works in the ACT, has recently purchased a nursing home care support franchise, and will be employing registered paramedics to undertake the same role as the RN, which will include palliative care, which is awesome. And Jenna, again from NZ, says one of the community nursing services here in New Zealand has just been given the green light to hire paramedics into both district nursing services and generalist palliative care services. So the change is coming, which is awesome. On that kind of note, obviously the 30 odd participants in our webinar today have a keen interest in palliative care, Madeleine. So I think they're a resource that you might want to tap into at some point in time. What's the best way for them to reach out to you?
Yes, great point, David. I'd love for those of you that are interested to discuss all things palliative paramedicine, which I will do at any time, to contact me via my email address, which I'm sure David will be able to share with you all. I also think you made a really good point, and that is recognising that there are many of you with a real passion for this, and I just extend the opportunity for you to share my research and these ideas with your colleagues, because I really wanted to preach to also the unconverted, to many of the paramedics that we captured in some of our qualitative interviews who share a fear or a hesitancy or a reluctance to take this approach to care, when we've also been able to capture the I guess, the gratitude that many paramedics feel when they're able to facilitate a home-based death, when that's the desire of the patient and the family. So spreading the word and, you know, increasing awareness of this important role and broadening scope of practice in paramedicine is just going further to recognising the incredible role that paramedics already play in care, and that they have the scope to broaden so much into the future. So, yeah, please share my email address.
Well, great, thank you. Look, we're really keen to contribute to your community of paramedic palliative care experts. So anything we can do to contribute by the CAA, we're very keen to be part of. On that great point, I think we can wrap up if there's no other questions from our audience. It was really great hearing your presentation, Madeleine. It's something that's close to my heart and close to the heart of all our other attendees today. So we wish you all the best in completing your research, and look forward to watching the progress. And we're really looking forward to seeing the framework when it comes out. And if the CAA can assist in distributing that or implementing it across services, we're very happy to assist.
Thanks, David. And a big mention to David also as one of our valued members of the advisory group. We're really appreciative for all of the advocacy that the CAA is already doing in this space. So thank you.
It's a pleasure. Thank you so much. Thanks, everybody. And thanks for joining. Our next webinar is on the 12th of December. We have the pleasure of hearing from Dr. Jan Thorst Gessner, who's a good colleague of ours, part of our GRA group from Germany. And Jan is going to talk about ventilation in EMS, manual or mechanical. So that should be an interesting conversation we'll have. So thank you all again, and we'll see you at the next webinar.
Thank you for attending Palliative Paramedicine, Challenging Perceptions, Building Paramedic Capacity and Embracing Integrated Models of Care. Until next time, be sure to follow us on social media to keep up to date. Twitter at CAA Australasia, and Facebook and LinkedIn, the Council of Ambulance Authorities. Thanks for joining us, and we look forward to seeing you next time.